A sloth, a donkey, and a curious human. Send a prompt and see what they're doing. One hits record with a question on his mind. Two brothers pick it up, see what they find. Corn takes his time, Herman's got the facts. Back and forth, they never hold back. My weird prompts, come on in, that's where we begin. My weird prompts, glad you're here.
This episode was generated using artificial intelligence. Please verify facts.
Hey, Herman and Corin. I would love to chat today about a class of medication that I think is potentially really interesting, but we don't see yet used that much. I'm talking about serotonin, norepinephrine, and dopamine reuptake inhibitors, or triple reuptake inhibitors. I've made no secret on this podcast about my own mental health trajectory and history, and that, like many people, I think I probably could have shaved a good 2 years, if not 3, off my trial and error process if I wasn't so resistant to the idea of taking more than one medication. I started out taking ADHD medicines, Ritalin, and then the longer acting ones. Then found that those edges or the crashes were really harsh. Added in Lexapro. Decided that Lexapro was the bee's knees and the solution to all my problems. And when I took away the ADHD med, I was back to square one in terms of not having enough drive or push or focus. So it took me so long, and I'm not even sure what it was about taking multiple drugs that I was so resistant to, but maybe it's this concept of polypharmacy. And I think if I had listened to that episode that we did about polypharmacy, or how many drugs can one be on, that I probably would have felt a lot less hesitant and scared to do it, because ultimately, that's what's worked for me, the cocktail of Lexapro and Vyvanse, and it's wonderful to not have had adjusted anything about the medication regime for at least a year, after you've spent a lot of time trying and erroring in drug trials. To reach that kind of point of stability is just, it's wonderful. So I guess one thing that's interested me when I look at what's coming out in medications, what's being worked on and developed, is this concept of a triple reuptake inhibitor. We think about the history of antidepressant drugs and that they started out as these much more broad-acting chemicals. I'm talking about the first generation, the MAOIs, that had the major issue that if you were a big fan of blue cheese or beer, you could trigger a hypertensive crisis. But they had quite surprising degrees of effectiveness that actually, if I'm not mistaken, sometimes even exceeds that of the SSRIs. Likewise, drugs like amitriptyline, which I've taken for something non-psychiatric, it definitely that stuff will knock you out. But for those who used it for depression treatment, again, often showing efficacy that was actually beyond that of the modern drugs. So we've cleaned up the drugs that we have in circulation, and they're more targeted, but sometimes, unfortunately, they're slightly less effective. So I'm really interested in this idea that for these previous drugs maybe didn't look so, their widespread effect of targeting different systems might have been part of why they worked so well. And this idea, if you take this, I think the combination of depression, mild depression, and ADHD is such an extremely common one, that rather than taking different drugs, if we could have one that would kind of push these three levers forward at once, that it would be potentially really useful. So Herman and Corin, I haven't seen or heard much about this space in a number of years. I don't know if any major drugs are in the trial stages or are in the actual use and prescription. But I'd be really curious to get your overview of where this class of medicines now. And I know there's a bit of a contradiction here. I've just told you that I spent a lot of time resisting taking multiple drugs, and now I'm back to thinking, well, actually it would be kind of nice to have one drug rather than two. But I guess that is ultimately a goal for a lot of people. Combination meds are really popular for a reason. They're more convenient, and it just is a bit less ridiculous bags of drugs that you come back with from the pharmacy when you wonder what on earth are the people behind me possibly thinking? So Herman and Corin, I'd love to talk about the history of triple reuptake inhibitors to date, what drugs are on the market now, what drugs might work, and do you think that there's a future in this class of medicine, or will we bypass it entirely in favor of the move towards much more personalized medicine, where we move away entirely from talking about things like depression and ADHD, and we just typify someone based upon their unique symptom profile and find a really personalized approach for their brain? Over to you two.
Hey everyone, welcome back to the show. We have a really fascinating topic to dig into today, sparked by a very thoughtful and detailed prompt from one of our longtime listeners, Daniel. Daniel is asking about a class of medications that sounds like the ultimate goal of psychopharmacology, but is proven surprisingly elusive in practice for decades. We are talking about triple reuptake inhibitors, or serotonin, norepinephrine, dopamine reuptake inhibitors, often abbreviated as SNDRIs. Daniel shared some of his own journey with managing the overlap of ADHD and depression, and it really got me thinking about why we are still often stuck using multiple different pills, what doctors call polypharmacy, instead of one single molecule that hits all the right targets in the brain.
Herman Poppleberry here, and Corn, you are right on the money. This is a topic I have been following for years because it sits right at the intersection of neuroscience, medical history, and the future of how we treat the human brain. Daniel's experience is actually incredibly common, though it is rarely discussed in these terms. The medical community calls it comorbidity, but for the person living it, it is just a daily reality of trying to balance focus and mood. The idea that we could have a single molecule that addresses all three major monoamine neurotransmitters at once is basically the holy grail of antidepressant and ADHD research. We have been chasing this since the 1950s, and yet here we are in February of 2026, and we are only just now seeing some of these drugs finally cross the finish line.
It is interesting because Daniel mentioned that older drugs, like monoamine oxidase inhibitors, or MAOIs, often seemed more effective for some people than the modern, hyper-targeted ones we use today. That feels counterintuitive in a world where we usually think newer is better and more precise is superior. Why did we move away from those broad-acting drugs if they worked so well for complex cases?
Well, it was a classic trade-off between efficacy and safety. Those early drugs were discovered almost by accident. In the early 1950s, researchers were testing a drug called iproniazid to treat tuberculosis. They noticed that the patients in the TB wards weren't just getting physically better, they were becoming incredibly cheerful, dancing in the hallways even. That was the birth of the first MAOI. But these drugs were like a general broadcast signal rather than a targeted beam. MAOIs work by preventing the breakdown of neurotransmitters throughout the entire body. But they also prevent the breakdown of other things, like tyramine, which is found in aged cheese, red wine, and cured meats. If you were on an MAOI and ate a charcuterie board, you could end up in a hypertensive crisis where your blood pressure spikes to dangerous levels. It was called the cheese effect, and it made these drugs very difficult to manage.
And then came the tricyclics, right? I remember my grandmother talking about those.
The tricyclic antidepressants, or TCAs, like imipramine and amitriptyline, were also very effective because they hit serotonin and norepinephrine. But they were what we call dirty drugs in pharmacology. They hit all sorts of receptors they did not need to hit, like histamine and acetylcholine receptors. That led to a laundry list of side effects: dry mouth, blurry vision, extreme sedation, and even heart rhythm issues if the dose was slightly too high. So, the pharmaceutical industry went for the sniper approach. In the late 1980s, we got selective serotonin reuptake inhibitors. The SSR is like Prozac and Zoloft. They were much safer, you couldn't really overdose on them easily, and they didn't require a special diet. But Daniel's point is that by being so selective, we might have lost some of the therapeutic power. If depression or ADHD involves multiple systems, then a drug that only touches one system is inevitably going to fall short for a lot of people.
So we traded the shotgun for a sniper rifle. But sometimes you actually need to hit a wider target area. Daniel mentioned he is currently taking Lexapro for the serotonin side, and Vyvanse for the dopamine and norepinephrine side. That sounds like he is essentially building his own triple reuptake inhibitor out of two different prescriptions.
That is exactly what he is doing. Lexapro is an SSRI, and Vyvanse is a prodrug of dextroamphetamine, which increases dopamine and norepinephrine. By combining them, he is covering all three bases, serotonin for mood and anxiety, and dopamine and norepinephrine for focus, motivation, and energy. But as Daniel noted, it is a complex balancing act. You have two different sets of side effects, two different metabolic pathways in the liver, and two different schedules to manage. The promise of a triple reuptake inhibitor, or an SNDRI, is that you could potentially get the synergistic effects of all three in a single balanced molecule.
So let's talk about the history of these triple inhibitors. If they are so promising, why aren't they the standard of care? I remember hearing about a few that were in development a decade ago, but it feels like the trail went cold for a long time.
It has been a very rocky road, Korn. There have been dozens of attempts to bring an SNDRI to market, and most of them have failed in late-stage clinical trials. One of the biggest challenges is what we call the ratio. You can't just turn up the volume on serotonin, norepinephrine, and dopamine at the same rate. The brain is incredibly sensitive to the balance between these three. If the dopamine component is too strong, the drug might have a high potential for abuse, similar to a street stimulant. If the norepinephrine is too high, you get heart rate and blood pressure issues. And if the serotonin is too high relative to the others, it can actually blunt the benefits of the dopamine, leading to that emotional numbness or apathy that some people report on SSRIs.
That makes sense. It is like trying to mix a perfect cocktail where if you add a tiny bit too much of one ingredient, the whole thing is ruined. Are there any specific drugs that almost made it but crashed at the finish line?
Oh, there are several famous failures. You might remember a drug called sibutramine. It was actually a triple reuptake inhibitor, but it was marketed as a weight loss drug under the name Meridia because the norepinephrine and dopamine components suppressed appetite so effectively. However, it was eventually pulled from the market in many countries around 2010 because of cardiovascular risks. Then there was imidafidine, also known as EB1010. It showed a lot of promise in early trials. It had a ratio of roughly 1 to 2 to 8 for serotonin, norepinephrine, and dopamine. But it failed to show enough of a statistical difference from existing treatments in phase 3 trials for major depressive disorder. It wasn't that it didn't work, it just didn't work significantly better than the cheaper, older drugs already on the shelf.
That seems to be the recurring theme. They either aren't safe enough or they aren't significantly better than what we already have. But is there anything currently on the horizon? Daniel asked if there are any in clinical trials right now, or maybe even available by prescription that we just haven't heard of.
There is actually some very significant recent movement. As of today, in early 2026, the most important drug in this space is Ansofaxine, also known as toluidine venlafaxine. This is a real breakthrough because it was actually approved for use in China in late 2022 under the brand name Ruoxanlin. Since then, it has been making its way through the regulatory process in other regions, including the United States. It is a triple reuptake inhibitor that primarily acts on serotonin but has significant clinically relevant effects on norepinephrine and dopamine as well.
That is a big deal. If it is already approved in a major market like China, that suggests the safety and efficacy hurdles can be cleared. How does Ansofaxine differ from the ones that failed in the past?
It seems to have found a better balance in that ratio we talked about. It is designed to be a potent serotonin reuptake inhibitor with moderate effects on norepinephrine and slightly weaker effects on dopamine. The goal is to provide the broad efficacy of the old tricyclics, but with the safety profile of a modern SSRI. In clinical trials, Ansofaxine showed improvements not just in mood, but also in physical symptoms like fatigue and cognitive symptoms like lack of focus. These are often the residual symptoms that SSRIs struggle to fix. People on SSRIs often say, "I am not sad anymore, but I still can't get out of bed or focus on my work." Ansofaxine aims to fix that by bringing the dopamine and norepinephrine systems into the mix.
Cognitive symptoms and focus. That brings us right back to Daniel's ADHD connection. If someone is dealing with both depression and ADHD, a drug like Ansofaxine could theoretically replace both the Lexapro and the stimulant. But I wonder about the regulatory side. Is it harder to get a multi-target drug approved because there are more variables for the FDA to look at?
Definitely. The FDA and other regulatory bodies generally prefer drugs that do one thing very clearly. When you have a molecule hitting three different systems, it is much harder to tease out which system is causing a particular side effect or providing a particular benefit. There is also the concern about long-term effects on the heart. Stimulating the dopamine and norepinephrine systems long-term requires very careful monitoring of blood pressure. We actually talked about some of the chemistry of focus back in episode 834, specifically how dopamine and norepinephrine work in the prefrontal cortex. It seems like the SNDRIs are trying to replicate that natural balance, but doing it with a single molecule.
We often use the analogy of a sledgehammer versus a fine-tuned instrument. It feels like the old drugs were sledgehammers, and the new ones are trying to be a set of very precise tuning forks.
That is a great way to put it. And that brings up another drug that is worth mentioning, Centanafadine. This one is particularly relevant to Daniel because it is being developed specifically for ADHD rather than just depression. Centanafadine is a dual reuptake inhibitor of norepinephrine and dopamine with a smaller effect on serotonin. So it is technically an SNDRI, but the ratios are skewed toward the ADHD side. It has been in late-stage clinical trials for ADHD in both children and adults. The data looks very promising. It seems to offer stimulant-like efficacy, but as a non-stimulant medication. If that gets approved, it could be a game changer for people who can't tolerate traditional stimulants or who have co-occurring mood disorders where stimulants might cause too much anxiety.
It feels like we are constantly on the verge of a breakthrough that never quite arrives. Do you think the problem is the molecules themselves, or is it our understanding of the diseases? Maybe depression or ADHD are just too broad as terms for what we are trying to treat.
You are hitting on the core of the debate in modern psychiatry. For a long time, we relied on the monoamine hypothesis, the idea that depression is just a chemical imbalance of these three neurotransmitters. But we now know it is much more complex than that. It involves neuroplasticity, inflammation, the gut-brain axis, and complex neural circuits. An SNDRI might be a more powerful tool, but it is still working within that old monoamine framework. This leads perfectly into Daniel's second question. Is the future of this class of medicine going to be bypassed by personalized medicine?
Right. If we can sequence someone's genome or use AI to map their specific symptom profile, do we even need a one-size-fits-all triple inhibitor?
This is where it gets really interesting. We touched on precision medicine in episode 690, and the consensus is moving toward the idea that we shouldn't be treating depression as a single entity. We should be treating Daniel's depression or Korn's depression. If we can identify that your specific version of depression is driven by a dopamine deficit in the reward center, we don't want to flood your brain with serotonin. That might actually make you feel worse, leading to that emotional blunting.
And if we give someone with a norepinephrine dominant profile a triple inhibitor, we might be putting unnecessary strain on their cardiovascular system for no reason. So, in that sense, maybe the reason SNDRs keep failing in large trials is that they work brilliantly for 20% of the participants, but do nothing or cause side effects for the other 80%. In a broad trial, that looks like a failure, even if it was a miracle for that 20%.
That is the one-size-fits-none problem. If we could pre-screen the participants to only include people with a specific triple deficiency profile, those drugs might sail through clinical trials. But our diagnostic tools aren't quite there yet. We are still mostly using questionnaires and clinical observation. We are trying to diagnose a complex chemical and electrical system by asking the patient, "How do you feel on a scale of 1 to 10?" It is like trying to fix a jet engine by listening to the sound it makes from 3 miles away.
So, where does that leave us? Our SNDR is a dead end, or a tool waiting for the right diagnostic framework?
I think they are a tool waiting for better diagnostics. But I also think we might see a shift toward what I call intelligent polypharmacy aided by technology. Instead of one molecule that hits 3 targets in a fixed ratio, we might use digital health tools and AI to fine-tune a combination of targeted drugs. Think of it like a soundboard where you're trying to find the perfect mix. Instead of a single master fader, you have individual controls for each frequency.
That is a compelling vision, but for someone like Daniel, that means more pills, not fewer. He mentioned the inconvenience and the daunting nature of polypharmacy. There is something psychologically appealing about one pill to fix it all. It feels less like you are a patient and more like you are just taking a supplement for your brain.
There absolutely is. And there is also the issue of drug-drug interactions. When you take 3 different medications, you have to worry about how they affect each other's metabolism in the liver. For example, some SSRIs can inhibit the enzymes that break down stimulants, leading to higher than expected levels of the stimulant in your blood. A single molecule avoids that particular headache because its metabolism is predictable. So there is still a massive market and clinical need for SNDR, is if we can get the ratios right.
Let's talk about the ADHD side of this specifically. We know that stimulants like Vyvanse are incredibly effective for ADHD because they increase dopamine and norepinephrine. But they are also controlled substances with a high potential for abuse and side effects like anxiety or insomnia. Could an SNDRI provide the focus of a stimulant without the crash or the addictive potential?
That is the big hope for drugs like Centanafadine. Because reuptake inhibitors work differently than releasing agents, which is what most stimulants are, they tend to have a smoother onset and offset. Stimulants like Adderall or Vyvanse essentially force the brain to release more neurotransmitters. Reuptake inhibitors just keep the neurotransmitters that are already there in the synapse for longer. It is a more subtle way of increasing the signal. We already see this with atomoxetine, which is a selective norepinephrine reuptake inhibitor used for ADHD. It isn't a controlled substance and it doesn't have that kick, but it also isn't as effective for many people as the stimulants. An SNDR, I would add the dopamine component back in, which is crucial for focus and motivation, but hopefully in a way that is more stable and less prone to abuse.
It is interesting that you mention stability. Daniel talked about how wonderful it is to have reached a point of stability after years of trial and error. That trial and error process is so exhausting for patients. If an SNDR, I could shorten that process by hitting more targets at once. That alone would be a huge victory for mental health care.
It would be. But we also have to consider the shotgun approach from a different angle. If you use a broad-spectrum drug when a targeted one would have worked, you are exposing the patient to unnecessary side effects. It is a bit like using a broad-spectrum antibiotic for a simple infection. It works, but it might be overkill and lead to other problems. This is why the future is likely going to be a hybrid. We will have these triple inhibitors for people with complex multi-system symptoms and more targeted drugs for people with simpler profiles.
What about the role of the prefrontal cortex in all of this? We've talked about the inverted U-curve of arousal before. Can you explain how an SNDRI interacts with that?
Sure. The prefrontal cortex, which is the part of the brain responsible for executive function and focus, needs just the right amount of norepinephrine and dopamine to function. If you have too little, you are distracted and unmotivated. That is the left side of the U. If you have too much, you are stressed, anxious, and scattered. That is the right side of the U. The goal of any ADHD or depression medication is to get you into that sweet spot at the top of the curve. The challenge with an SNDRI is that you are trying to push 3 different systems into their respective sweet spots at the same time with one dose. It is a very difficult balancing act for a single molecule.
So, to summarize the current landscape for Daniel, we have Ansofaxine, which is already being used in China and is moving toward approval in the West. We have Centanafadine, which is looking very promising for ADHD as a non-stimulant triple inhibitor. And we have a lot of research into how to better identify which patients actually need this triple action approach.
And we shouldn't forget about the role of pharmacogenomics. There are companies now that offer genetic testing to see how you metabolize different psychiatric drugs. It can tell you if you are a fast metabolizer of certain enzymes, which might explain why a certain dose of Lexapro doesn't work for you. But what we don't have yet is a test that says, your brain has a 30% deficit in dopamine reuptake transporters, so you need this specific SNDRI. That is the next frontier, moving from how the body processes the drug to how the brain responds to it.
It feels like we are in this awkward middle phase of medical history. We have the old, broad-acting drugs that were effective but messy. We have the new, targeted drugs that are safe but often insufficient for complex cases. And we are looking toward a future of total personalization that isn't quite here yet. The SNDRIs are trying to bridge that gap.
They really are. And I think it's important to acknowledge the role of the patient in this. Daniel's willingness to experiment and find the right cocktail is what eventually led to his stability. But not everyone has the resources, the time, or the medical support to do that. For many people, if the first SSRI doesn't work, they just give up on treatment entirely. That is the real tragedy. If we had an SNDRI as a first-line or second-line option, we might be able to help those people much sooner.
The daunting nature of polypharmacy isn't just about the number of pills. It's about the mental load of managing a complex medical regimen when you are already struggling with depression and ADHD. If we could simplify that, we would improve adherence and outcomes significantly. Imagine just having one bottle on your nightstand instead of 3 or 4.
And we shouldn't overlook the role of non-pharmacological interventions too. Daniel mentioned he's found a good balance with his meds, but we've talked in the past, like in episode 688, about how things like diet and exercise can interact with these medications. For example, protein intake can affect how a drug like Vyvanse is processed, because it relies on amino acid transport. With an SNDRI, those interactions might become even more complex because you are dealing with 3 different neurotransmitter systems at once.
It sounds like a lot for a doctor to manage, let alone a patient. I wonder if the rise of AI in healthcare will help here. If an AI can monitor a patient's sleep, heart rate, and mood in real time through a wearable device, it could help a psychiatrist fine-tune the dosage of a complex drug like an SNDR. I'm much faster than the current see you in 6 weeks model.
I think that is exactly where we are headed. We're going to move away from the idea of a static prescription and toward a dynamic one. And in that world, a drug that hits multiple targets might actually be easier to manage because the AI can see the holistic effect on the brain's chemistry. We are moving from a world of snapshots to a world of continuous video.
So, to wrap this up for Daniel and our listeners, the history of SNDRIs is a story of great promise met with significant technical and regulatory hurdles. We had the broad-acting MAOIs and tricyclics, which worked but were risky. We moved to SSRIs for safety but lost some efficacy. Now, in 2026, we are seeing a resurgence of interest in triple inhibitors like Ansofaxine and Centanafadine, which aim to find that sweet spot ratio.
Right. And while personalized medicine is definitely the future, it is likely going to coexist with these broader drugs for a long time. Some people will always benefit from a more comprehensive triple approach, especially those with complex comorbidities like ADHD and depression. The key will be using better diagnostics to figure out who those people are before they have to spend years in the trial and error phase.
It is also worth noting that for anyone listening who is in that trial and error phase right now, there is hope. As Daniel's story shows, finding stability is possible, even if it requires a bit of a pharmaceutical jigsaw puzzle for now. The science is catching up to the reality of these complex conditions.
Well said, Korn. And if you are interested in the nitty-gritty of how these specific medications work, I highly recommend checking out our deep dive into the science of Vyvanse in episode 485. It really explains why that dopamine-norepinephrine combo is so powerful for the ADHD brain.
And if you want to understand more about the broader challenges of managing ADHD and physical health, episode 495 is a great companion. Listen, we really get into the bureaucratic and medical hurdles that Daniel alluded to in his prompt.
This has been a great exploration. It is one of those topics where the more you learn, the more you realize how much we still have to discover about the human brain. But the progress is real. The fact that we have an SNDRI approved in a major global market now is a huge milestone that seemed impossible 10 years ago.
Definitely. Before we wrap up, I want to say a huge thank you to Daniel for this prompt. Your openness about your journey really helps ground these technical discussions in the real world, and I know it resonates with a lot of our listeners who are navigating similar paths.
It is why we do the show. Hearing from people who are actually using these medications and asking these deep questions keeps us on our toes.
If you are enjoying my weird prompts, we would really appreciate it if you could leave us a review on Apple Podcasts or Spotify. It genuinely helps other curious minds find the show and join the conversation.
You can find all our past episodes, including the ones we mentioned today, at myweirdprompts.com. We have a full archive there and a contact form if you want to send us a prompt of your own. You can also email us directly at show@myweirdprompts.com.
We are available on Spotify, Apple Podcasts, and pretty much anywhere else you get your audio fix. Thanks for joining us today for this deep dive into the world of triple reuptake inhibitors.
It has been a pleasure. We will be back soon with another deep dive into your weirdest prompts. Until then, stay curious.
This has been My Weird Prompts. I am Corn.
And I am Herman Poppleberry. We will see you next time. Goodbye.
Goodbye, everyone.
This episode was generated using Gemini Flash 3. Text-to-speech engine was Chatterbox.
Thanks for listening to our show, My Weird Prompts, where our thoughts go from slow takes to facts on cue. We change and follow through. My Weird Prompts, that's the close from sloth, from man, from law.